everybody, I'm back again. I'm Missy Scalise. I'm a general internist, and you've tuned into a very efficient use of your time where we do a treadmill workout, and then we also talk about kind of the newest medical topics in the news. And so it's just a really efficient part of your day. It's really geared more towards general internists because that's kind of what I do. But I think if you wanted to stay up to date with a lot of different medical topics, really anyone within medicine might find these valuable and educational. So that's kind of what we're going to be doing. The treadmill workout itself is going to be alternating bases and pushes. Now, bases are just kind of your baseline intensity. You can do it for a long time. For me right now, that's going to be between a 2 and a 3 miles per hour walk. And then that's going to alternate with pushes. And for me, that's going to be between a 3 and a 4 mile per hour walk. If I go any faster, I can't talk. So gotta go a little bit slower. But you can really make your bases and pushes whatever you want. So you might find that you want to walk and then jog, or jog and then run, some of those. So just really make it whatever works best for you. I will say that I am not a fitness instructor, and so make sure that you stretch before and after this. If you have not stretched yet, I would go ahead and just pause this for a second, get your stretch in, and then restart. All right. So the first kind of so we're going to talk about a number of different topics. I'm also going to intersperse some questions in there to kind of help engage and reinforce some of the concepts we're talking about. So the first kind of topic we're going to talk about is with our first push. So let's go ahead and increase to a push. For me, again, that's between 3 and 4, but you do you. So we're going to start actually with a question. So a 50-year-old male with a history of tobacco use disorder comes in for follow-up after starting varenicline when he told me he was ready to quit smoking. That was 6 weeks ago. He's been taking it regularly, and it has reduced his cravings, but he has not completely quit now. And he's wondering kind of what is the next best effective thing to do at this point. So 4 different options. A, we continue the varenicline for another 6 weeks for a total of 12 weeks. B, we increase the varenicline to 3 milligrams for the next 6 weeks. C, we switch to nicotine replacement therapy. Or D, we switch to bupropion therapy. And I'm going to let you kind of think on that for a second. The question should be above or below wherever I decide to kind of put it on here. So give it a moment to think about what you would do. All right, so the answer really is to go ahead and increase the varenicline to 3 milligrams. And that's based on a recent study where they took patients who were smokers. They randomized them to either varenicline or nicotine replacement therapy. They followed up with them at 6 weeks. And then for those in the varenicline group, they either continued the 2 milligram dose, they increased it to 3 milligrams, or they switched completely to nicotine replacement therapy if they were not quit at that 6 week mark. So for a total of 12 weeks. And then they looked to see who had quit. And those that at the 6 week mark hadn't completely quit, but were increased to 3 milligrams, actually showed a 20% quit rate compared to those who had just been maintained on that same dose, who had quit at 3%, which is a pretty large percentage. And then for those that had switched to nicotine replacement therapy from the varenicline, 0% of them quit. So that kind of helps support that at the 6 week mark, if patients are completely quit with varenicline, we can go ahead and increase that dose to 3 milligrams, and it is more effective for those patients. It also showed, they took a look at those that were on the nicotine replacement therapy at the 6 week mark. If the patients weren't completely quit at that point, I'm going to go ahead and have you guys go to base now. All right. So those that hadn't completely quit, that were on the nicotine replacement therapy, they randomized those to increasing the nicotine patch to 2 of the 21 milligram per day patches versus to switch them to varenicline versus just to continue the same patch. And they also found that if you increase the dose of nicotine patch to 2 patches per day, that was just as effective as switching to varenicline for that patient population. Those that both of those had a quit rate of 14%. Those that continued that patch and just continued the same dosage only quit at 8% rate. So this study really helps support for those patients that aren't quit at the 6-week mark. We can go ahead and increase the dose of either nicotine patch or the varenicline, and it can be more helpful for them. So I think that's something that I'll kind of start to put in my repertoire for my patients that have tobacco use disorder. All right. I'm going to go ahead and have you guys start pushing. We had a little shorter base. All right, the next topic I wanted to tell you guys about was calcitonin gene-related peptide antagonists. Now, these have been out for a while for the treatment of migraine headaches. They are used for both prevention and for abortive therapy for migraine headaches. There are monoclonal antibodies, which are injections, and then there are also a category called GPANTs, all within the CGRP antagonists category for migraine treatment. They're very well tolerated, especially compared to some of the other agents that we have. There's not a lot of contraindications for these medications, so that's been helpful for treatment as well, and they're pretty effective. So much so that the American Headache Society recently came out and said that calcitonin gene-related peptide antagonists should be used first line for prevention of migraines. And that's based on a bunch of data that they've analyzed and really came up with the fact that these are safe, they have good efficacy, they probably work a little bit faster than some of the other agents, and they, especially related to side effects, they have a lot less side effects than some of the other agents. So I use a lot of propranolol and TCAs for migraine prevention, and they have side effects for patients often. The CGRP antagonists don't have a lot of side effects, so that's really helpful. Even though they're recommended as first-line therapy for prevention of migraines, I think it's going to be hard, at least right now, for patients to get these medications because they're still very expensive, and insurance often requires the patient to have tried a couple other agents before these are used, before they'll cover them. I think this will change over time as CGRP antagonists become more affordable and insurance is able to cover them a little bit better. So stay tuned. And that's the next topic. That's all done. Well, on to the next topic. We're going to go ahead and go to base. How you guys doing? Learning something? I learned so much doing this. So I want to thank you for tuning in, but I think I would do this regardless of if no one tuned in, and probably no one will tune in anyway. So anyway, I hope this is helpful for somebody out there. The next topic is actually an interesting, it's a vibratory device for supine predominant obstructive sleep apnea. So this is something that actually kind of goes on the chest or the neck and is really available to those that have sleep apnea when they're in supine position. And when patients have this on and they go to the supine position, it vibrates to kind of give them some feedback to switch positions. So it's not a CPAP. It's not, a more invasive intervention. It's just something a patient can kind of wear to give them some feedback while they're sleeping to reduce the risk of sleep apnea in those patients that really have it mainly when they're in the supine position, because there are those patients out there. For those patients that have it mainly in the supine position, when they wore this, it decreased sleepiness similar to CPAP, It was not quite as effective as CPAP, but is, a possible alternative for patients that don't tolerate CPAP and are in that supine predominant OSA category, or those that, maybe for some other reason can't use a CPAP. So either don't tolerate it or have some facial issue or something like that where they can't use a CPAP. So just kind of something I thought was non-medicine, not a CPAP for sleep apnea that's been shown to maybe be somewhat helpful for that group. All right, we're going to go ahead and we're going to push. All right, so that's the third topic. All done, check done. Next topic, we're actually going to start with a question. So there's a 45-year-old male patient with HIV who comes in for his annual. He has no complaints. He's doing great. When you check his lipid profile and calculate his ASCVD risk using the PREVENT calculator, if you don't know what that is, watch my last video. His ASCVD risk is 6%. So what is the next intervention you should recommend for this patient? 4 options. A, statin therapy. B, stress testing. C, fish oil. Or D, continue to monitor and give lifestyle counseling and wait till the risk is greater than 7.5 for the ASCVD risk. All right, I'll give you a minute to kind of think about those options. All right, so the answer is actually A, statin therapy. So there's a newer kind of guideline that for those patients with HIV, they do happen to be at increased risk for cardiovascular disease for a number of different reasons. One being it's more of a pro-inflammatory state, and that increases the risk of heart disease. So for this patient population, for those that are over 40 and have an ASCVD risk greater than or equal to 5%, we should be using or recommending statin therapy. Obviously, patients have to be open to it, but we should be recommending that for patients. So greater than 5%, statin therapy for over 40 years of age for patients with HIV. All right. We're going to go ahead and go to a base. All right, so that was the 4th topic. We're on to the 5th. The next one we're going to talk about is something near and dear to my heart, probably yours too. So actually, there's new data to suggest that exercise is just as effective for mild depression as pharmacotherapy. So they took a bunch of different studies and did a meta-analysis and noted that for mild depression, light to moderate activity, several sessions a week. So most studies did 30 to 60-minute sessions at least 3 times a week. That has been shown to improve depression, really similar to medication, which is really a great option. I think a lot of patients, especially those with mild depression, are a little bit hesitant to start medication for whatever reason, multiple reasons. And now we have some data that says, maybe if they're, not really wanting to do medication, another option that's not, pharmacotherapy is actually just exercise. And that's good for our patients' overall health anyway. So just another reason to support regular exercise for patients. That exercise in those studies included walking, jogging, yoga, strength training, and then even Tai Chi. So a lot of different options. So I think in my patients that have mild depression, in those patients that I talk about a number of different options. So I usually talk about counseling plus medicine by itself, with my preference being medicine plus therapy for some patients, or just counseling. But now I think we can start actually giving another option is starting exercise. I do think it's going to be important to follow up with those patients and just make sure that they're responding to that intervention. Sometimes when I recommend diet and exercise, I don't follow the patients up as closely as when I start pharmacotherapy. So I'm just going to have to make sure that I follow these patients up just like I would if I were starting medicine. But just something to kind of consider for those patients. Right, we're going to go ahead and go to a push. All right, so that was topic 5. We are on to we'll do 6. So for those people that see patients with acute complaints, namely sudden sensorineural hearing loss, that's an important thing to recognize, an important thing to refer to ENT and also to start steroids for. So patients will just kind of come in complaining of usually unilateral hearing loss, can be bilateral, but usually unilateral. And you'll look in their ears, you don't see anything, no cerumen blocking or anything like that. And then you worry about the sudden sensorineural hearing loss. So they actually, some people, when they're treating this, they use high dose steroids, even IV steroids and like 40 milligrams of dexamethasone. So they did a study where they compared all of those to the 60 milligrams of prednisone, which is what I use for 5 days, followed by a 5-day taper. And they found all of those were equal because you don't get as many side effects to the 60 milligrams of prednisone compared to, say, the IV steroid. The recommended dosing is really just to use that prednisone. So for sudden sensorineural hearing loss, we should be using 60 milligrams of prednisone for 5 days, followed by a 5-day taper, and then obviously a referral to ENT. All right, we're going to go ahead and go to a base. Oh, I'm getting a little out of breath. That's good. Okay. All right, the next topic is something I thought was interesting and something I'm going to start counseling my patients on. So for patients that are started on semaglutide, there may be an increased risk of non-arteritic anterior ischemic optic neuropathy. And that basically came from a study where they retrospectively matched a cohort, and they found that patients that were prescribed semaglutide had a hazard ratio of 4.2 compared to for those that were exposed to semaglutide compared to those that had not been exposed. And obviously this needs to be confirmed and the causality needs to be determined before we can say for sure this is the cause. But I think this is enough information to kind of be concerned about it. The study was really spurred on by some physicians who had noticed this happening to patients on semaglutide, and so then took a look retrospectively at it. So I think I'm starting to kind of tell my patients about this possibility when I start them on it. So far, since I've known this, only had one patient where I told him about it, and he was concerned, but not concerned enough not to start it. But I think everyone needs to kind of go into it eyes wide open. So something to note, I'm going to have you guys go to a push, and this will just be for about a minute or so, and then we'll go down to a base, and then we'll be done. So we went through a bunch of different things. I hope that you have kind of learned something from this. I know I definitely do. The main take-home things for me are to kind of increase that nicotine therapy, so the nicotine replacement therapy, and then the varenicline in those patients that don't initially respond to regular dosing. And then the other thing is to really recommend statin therapy for those with even a 5% or more risk if you have HIV and are over 40. And then the mild depression being treated with exercise. All right, go down to a base. And we're just about done, about 40 seconds or so, and we'll be done. So those were my main kind of takeaways from today. I will continue to kind of put these out every once in a while as I have time and as there are new things coming out. If you have any suggestions for me, I'm totally happy to take any suggestions, feedback. And I just want to really thank you for being a part of this workout. I hope you enjoyed it, and I hope it was a really efficient use of your time. All right, have a good day. Go make sure to stretch, okay? Bye.